So I want to acknowledge with gratitude how privileged I feel to be on this land. We are hosting this session on the unceded and ancestral territories of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh nations, and the Métis Charter Community of the Lower Mainland region. And all of you, wherever you are in this province or anywhere else on Turtle Island, are, I hope, thoughtful about the land on which you are and the elders past, present, and emerging. Next. So a reminder that this province-wide rounds is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. It was made possible by generous contributions in time from all of you and the health authorities and from our corporate sponsors, so that we actually have the highest quality education and access that we can. So thank you all for your contributions. Next slide. So it's really a privilege and a pleasure to be able to introduce Dr. Matt James. Dr. James is a specialist in nephrology and associate professor in the Department of Medicine and Community Health Sciences at the University of Calgary. Importantly, he received his medical training at UBC and then completed his nephrology training and PhD at University of Calgary. He's currently the co-lead of the Alberta Kidney Disease Network and the Interdisciplinary Chronic Disease Collaboration called ICDC, as well as a co-lead of the CanSolve CKD Strategy for Patient-Oriented Research Network. He's also the director for research for the Alberta Provincial Project for Outcomes Assessment in Coronary Artery Disease, known as APPROACH. And importantly, Dr. James has focused his research on risk prediction, computerized decision support tools, and pragmatic trials designed to improve the quality of care and health outcomes of people with kidney and cardiovascular diseases. He has extensive research funding from CIHR and Alberta Innovates, and it's been recognized that his work is incredibly important with a Mid-Career Research Leader Award from the O'Brien Institute at the U of C and a Killam Emerging Research Leader Award. So really a privilege to have him here to speak with us, an important topic about what we can do about updating research and care for people with acute kidney injury. So I'm going to turn it over to you.
Thank you very much for the really nice introduction, Adira. It's really nice to be able to present to you in British Columbia today. And I'm going to focus on some recent research that our group and others have been involved in acute kidney injury in patients in hospital. I'm at the University of Calgary, as mentioned, and I would like to acknowledge the people of the Treaty 7 region that I live and work on. That includes the Blackfoot Confederacy, as well as the Tsuut'ina First Nation, the Stoney Nakoda, and the city of Calgary is home to Métis Nation of Alberta Region 3. And I'll just disclose my grant funding for some of the work presented here. It includes CIHR and Alberta Innovates and the CanSolve CKD Chronic Disease Network. So in this talk, I wanted to try to cover 3 objectives. The first is to be able to recognize some evidence-based approaches to prevent acute kidney injury in the hospitalized patient. And I'm going to really focus on acute kidney injury in the setting of coronary heart procedures, where there's some recent publications to provide more evidence in this area. I also want to talk a little bit about interventions for recognition and responding to acute kidney injury in more generalized hospital patients, and look at some of the differences in the pragmatic studies and trials that have been done to try to understand why some of these interventions have been effective and have not. And then finally, I will just end touching on some principles of implementation science and how I think they've influenced this field of research. So I'm going to start on this topic around preventing kidney injury in the setting of cardiac catheterization. So there's been a lot of evolution of work around the role of contrast volume contributing to this, and how implementing strategies to lower the amount of contrast volume being used could reduce acute kidney injury. So there was the development of quality improvement initiatives in the United States to try to lower the amount of radio contrast dye being used in procedures, and even the development of tools and models to try to predict what a safe contrast limit could be for patients, whether they have kidney disease or not, or other comorbidities. So often this is driven by multiple risk factors and determining the thresholds of contrast that would elevate risk significantly. And then also in the field, we've known for many years that there's a role of hydration for clearing contrast and preventing acute kidney injury, but there was really a lot of refinements evolving the literature about making this a more personalized strategy. So instead of giving every patient the same standardized amount of fluid, which might be enough for some or too much for others, personalized strategies for delivering fluids guided by hemodynamic parameters, which are easily measured during cardiac catheterization, started to evolve. And some trials were published actually showing that taking this personalized approach where patients with lower filling pressures would receive more fluids actually reduced acute kidney injury in this setting as well. In Alberta, we noticed that there was large variation in the amount of contrast being used across physicians. So this graph just shows how on the left, the average amount of contrast dye used by the physician on the far left is actually much smaller than that at the physician on the far right. And that's about 28% actually of the variation in the amount of contrast is attributable just to the physician themselves after adjusting for a number of physician, procedure, and patient differences. We also observed in Alberta that were large differences between sites in the amount of contrast dyes and fluids being used that couldn't really be explained by any differences in patient mix. And interestingly, you know, if you thought we were doing a good job in this, you would think that in the highest risk patients, we'd be using the least amount of dye, but that actually wasn't the case. This was pretty consistent across all levels of risk. So this is before the pandemic now, several years ago, but in Alberta, I was involved with the cardiology groups in developing this multifaceted intervention to try to prevent acute kidney injury across all the cardiac catheterization units in the province. And so what it involved is implementing in the clinical information system that exists in the cardiac catheterization units a risk model to actually predict the risk of acute kidney injury in each patient coming through and identify those at increased risk of acute kidney injury. Embed in that clinical information system a decision support tool that actually estimated and showed safe contrast limits for each patient, as well as the IV fluid recommendations based on the hemodynamic parameters, and actually produce a recommended order for intravenous fluids during and after the procedure, and then a follow-up process to have all high-risk patients have their kidney function checked and a follow-up step undertaken. And then we implemented this, you know, really with a foundation of the computerized clinical decision support tools, but also providing one-on-one education sessions to each invasive cardiologist by a site champion, and then introducing an audit and feedback process. So each physician could see how they were doing on the major metrics of contrast volume, fluid administration, and their AKI incidence. So this is just a look at what the clinical decision support tool in Alberta looked like. You could press a button to bring up this risk score and then enter clinical information. A lot of this gets pre-populated into the registry, so they just have to modify any variables and then execute the risk score. And then this would actually give a risk of acute kidney injury for each patient and stratify them into above risk or particularly high risk categories. And then the risk model would also be run to actually estimate what a safe contrast volume would be for each patient, and that would be shown graphically. And a timeout would occur in the cath lab, and this would be reviewed, and the procedure would be planned in a way to try to take the safe contrast limit into account. At the same time, after an LVEDP measurement was taken, actually a recommendation for IV fluid was generated. So again, higher amounts for those with lower LVEDPs, and this would then be transferred into the electronic order set. And this is a look at what a physician audit and feedback report looked. Every 3 months, physicians would receive this audit and feedback report. And what this funnel plot here is showing is this would show, a physician and their contrast volume within this plot showing all of their peers. So you can show that you are lower than the average and lower than many of your peers. And these lines in the funnel plot show when you're really practicing outside the control limits that would be expected. And then these reports would actually summarize your performance over time on safe contrast limits, fluid volume, and the acute kidney injury incidence. So we evaluated this in a cluster randomized trial. It was a stepped wedge trial where 8 clusters of physician groups across the province doing invasive procedures were randomized to different times to start receiving this multifaceted intervention. So in the beginning, we have a period where none or very few physicians and their patients are receiving this intervention. By the end, all physicians and the patients they care for are being exposed to this intervention. So we focused the trial just on the patients with a predicted risk of acute kidney injury that exceeded 5%. That was about 25% of all patients that come through the cath labs. We had this multifaceted intervention, which I just showed you the components, and our primary outcome was to see if we could reduce the incidence of acute kidney injury by doing this based on creatinine criteria. And then we had secondary outcomes that were process of care measures, so the contrast volume, the intravenous fluid administration, days in the hospital after procedures, and then major adverse cardiovascular and kidney endpoints like dialysis, death, recurrent MI. So this figure shows the flow of this cluster randomized trial. There was 34 physicians included in the trial at the outset. 3 ended up retiring during the process of the trial. So there was 31 who actually went on to receive the intervention, and just under 8,000 procedures were included in the trial. And so just to show you how this would work in a step wedge trial, you would start off, if you were randomized to the first step, you would start off with a short period of time with data collected before you receive the intervention. You would then receive the intervention, and for the rest of the follow-up time, you'd be exposed to the intervention and analyzed within that group. So we have our pre-intervention and intervention groups in the end, versus if you were randomized to the 5th group, you would actually step over to start receiving the intervention later and have fewer patients subsequently in the remainder of the trial in the intervention group. These are the baseline characteristics. There were about 4,300 patients or procedures in the intervention group, and 3,493 procedures in the control group. The 2 groups were similar on all prognostic factors. About 65% of patients were actually undergoing procedures for an acute coronary syndrome, and they had a predicted risk of 6.7% risk of acute kidney injury, and a fluoroscopy time of 7.7 minutes, which is a bit of a marker for the complexity of these procedures. So moderately complex procedures on average. This graph shows the effect of the intervention on our main process of care outcomes, and shows that the intervention did reduce the number of cases where the safe contrast volume was exceeded, and also reduced the number of cases where patients received less than the hemodynamically guided intravenous fluid recommendation. So both measures modestly improved. And this figure shows a graph of the primary outcome of acute kidney injury over time, the red showing in the control group and the blue showing in the intervention group. Over the effect of the intervention in the trial, the incidence of acute kidney injury fell from 8.4% before the intervention or in the control period to 7.2% with the intervention. So in adjusted models that account for the design of the trial and any potential differences, there was about a 30% relative reduction in the incidence of acute kidney injury and a 2.3% absolute reduction in the risk of acute kidney injury. This effect was consistent across all the pre-specified subgroups that we looked at. The major adverse clinical outcomes did not significantly differ between the two groups. There was no significant difference in major adverse cardiovascular events or the components of that outcome, or major adverse kidney events. Although numbers were lower in the intervention group, the trial was not powered to detect these clinical outcome differences. So in summary, in this study, we found that actually combining education with decision support and an audit and feedback process did change care practices and lowered the incidence of acute kidney injury. And is really a scalable intervention if you do have electronic medical records, the resources to produce audit and feedback reports. And I think you need some quality of culture improvement to support the change with this sort of intervention. The number needed to treat for this is 44. So that means 44 of the patients in this trial, for every 44 patients meeting eligibility criteria for this trial, you prevent 1 episode of acute kidney injury. And based on our estimates of cost in Alberta for each episode of acute kidney injury, mainly through affecting testing, subsequent testing, and length of stay in hospital, this can save, we project this saves about $1.5 million each year in Alberta in the cardiac catheterization units. If this affected dialysis, of course, this would have a much greater effect on costs, but we did not include this in these projections. Interestingly, just recently, a very similar type of approach was reported from a large number of centers in the Veterans Affairs Network in the United States. So they looked at over 4,000 patients, 500 of them who experienced acute kidney injury. And they actually did a factorial cluster randomized trial where they randomized physician groups to receive really 2 different interventions. One was assistance, which is where they provided their groups with a bundle that focused on teaching strategies to reduce contrast volume and provide intravenous fluids. And this was provided as a package of materials with 1 phone call delivered to the group to promote them and tell them what the materials included and promote their use. The other arms of the trial actually involved a collaborative. So in the collaborative, not only did they receive the bundle in each center, but the physician groups also had the involvement of a dedicated quality improvement specialist and had monthly learning collaborative meetings where they actually met to discuss the bundle, how they were using it, developed goals on a monthly basis for improving their practices, and then continued to do that throughout the trial. And then the third level of intervention was actually surveillance. So this actually involved, like audit and feedback reporting, a dashboard that these centers and physicians could actually receive, so they would get almost real-time feedback on their observed compared to expected number of acute kidney injury episodes in their patients, and also just a review of their contrast volumes and fluid use. So this shows how those 3 interventions ended up in a factorial design, kind of creating 4 groups, the virtual learning collaborative, a virtual learning collaborative where they also got the surveillance reporting, the assistance only, so that was the minimal amount of education really, and then the combination of the technical assistance plus the surveillance reporting. And this just shows you what their dashboard for surveillance reporting looks like. A physician could see their observed versus expected incidence of acute kidney injury. So if they were exceeding what would be expected, this would show up here, and they could review their cases here and see their trends over time. And this actually shows their data. So they, their outcomes, they had about a 8 to 12% incidence of acute kidney injury, so a bit higher than what we saw in Alberta across their groups. And there was actually an increase in the incidence of acute kidney injury in the group that only had the minimal amount of the intervention with assistance, whereas there were small reductions in the incidence of acute kidney injury in the groups that had collaborative with surveillance. And this tended to range between a 3 to 5% absolute reduction in the incidence of acute kidney injury with these interventions. So this is shown here in models that are crude and adjusted, showing the significant reductions in acute kidney injury with this strategy. And it looks like the most effective was the group that received both the collaborative learning meetings on a regular basis, as well as the surveillance. And this was consistent across all patients, as well as the about 20% of patients who had chronic kidney disease. I'm going to move on now to shift out of the discussion around preventing kidney injury in cardiac catheterization, really into patients who have acute kidney injury in hospital. And this is just some results from a study we did in Alberta several years ago, just looking at the frequency and impact of acute kidney injury in terms of its relationships with mortality in hospital and 1 year length of stay and hospital costs, and how these rise substantially in patients with acute kidney injury. And in Alberta, they kind of evolved over time to become particularly interested in this on our surgical wards over time, as we really kind of honed in on identifying this group of patients on hospital wards developing acute kidney injury as perhaps being the ideal one to try to look at improving in care and studying an intervention to improve care. And so we ended up developing, again, a clinical decision support strategy that became embedded in our hospital EMRs at the time, that had a number of different tools to help recognize and respond to patients with acute kidney injury on these surgical wards. So we actually developed alerts, much like they have in the UK and have been studied in some places in the United States as well, to review the creatinine measurements in the electronic medical record and produce alerts when KDIGO AKI criteria based on creatinine were met. We also developed because this was in our EMR, we actually linked this to the medication order entry to actually within the alerts flag medications that might be affecting kidney function or have adverse events with reduced kidney function, following an approach developed in the United States for identifying relevant medications to acute kidney injury. And then we developed a dashboard in the electronic medical record for every patient where you could easily kind of review all the relevant information for acute kidney injury for that patient, and an order set that these alerts could take you straight into to guide you through common types of tests and interventions that you might do in the early stages of a patient with acute kidney injury after surgery. And this was all actually embedded in a kind of a knowledge resource that could then be acquired through the web to kind of give training and information about acute kidney injury. And we set off and did a lot of medical education to the surgery residents as they came onto each ward and the surgery groups. So this was the EMR, it was the Sunrise Clinical Manager at the time, and this is a blacked out patient list, but if a patient developed acute kidney injury, they would get a flag in the alerts column on the page. This was non-interruptive, but if you clicked on that red flag, you could pull up an acute kidney injury alert, and it would tell you what stage the patient had. It had some reminders just about, in the setting of perioperative care, about ensuring adequate volume status and the blood pressure of the patient, and then would actually link any information about medications that a patient was on that might be affecting their kidney function would be populated into the alert as well. And this is a picture of the dashboard, so it would show you any alerts. These would advance if the stage of acute kidney injury increased. It would show you the creatinine trends, the health issues of the patient. It would list the medications that affect kidney function or might need dose adjustments in the setting of reduced kidney function, and then give graphical summaries of things like fluid balance, ins and outs, blood pressure, white blood cell count, just to make people think about sepsis, just to kind of trigger the thought processes around the care of a patient with acute kidney injury after surgery. And this was that order set that went through diagnostic testing and had easily to use fluids therapy and monitoring strategies. So we also used the step wedge design to evaluate this in patients on eight surgical wards in Alberta, 4 in Edmonton and 4 in Calgary. We had the combination of education and the support tools in the electronic medical record. And our primary outcome that we examined was progression of acute kidney injury. So moving up a KDIGO stage or developing or ending up being treated with dialysis while in hospital or dying. And then we had a number of process of care outcomes related to investigations and consultations, IV fluid use, medication changes, length of hospital stay, and recovery of kidney function by the time the patient was discharged. So again, this was also a step wedge trial. So this looks very similar, although the numbers are different. Across the 8 hospital wards, 2 were vascular surgery wards, 1 in each of Edmonton and Calgary. There were 4 general surgery wards, which had a mix of acuity. These did include the solid organ transplant wards in Edmonton and the higher risk surgery wards in Calgary that have hepatobiliary and colorectal surgery on them, and then 2 trauma, they're really mixed trauma and general surgery wards. There were 2,135 admissions with acute kidney injury and 2,084 eligible patients in the cluster trial in the end, and the control group had 1,022 admissions, and the intervention group had 1,113 admissions. So these are the baseline characteristics in the 2 groups. About 20% were vascular surgery procedures. About 35% were intra-abdominal surgeries, 15 to 16% musculoskeletal, and then a range of other types of surgeries. In terms of comorbidities, there was a pretty high incidence of prevalence of diabetes, around 30%, and hypertension in 20 to 25% of patients. Very few patients with heart failure. We did not include the cardiac intensive care unit. The baseline EGFR was fairly preserved, 70 mils per minute, and most patients had stage 1 acute kidney injury, but 14 to 15% did go on to have stage 2 or stage 3 acute kidney injury. In terms of outcomes, this figure shows the process of care outcomes in the intervention and control group. So the first here are testing and consultation for acute kidney injury, including obtaining a urinalysis, doing an ultrasound, or consulting nephrology or internal medicine. And there were no significant differences between the 2 groups in any of these tests or consults. The second part of the figure here shows therapeutic interventions. So this top row is a composite of fluid administration, withdrawing diuretics, or withdrawing medications that might affect kidney function, including NSAIDs, ACE inhibitors, antibiotics, or other agents that can reduce kidney function. And again, here we saw actually no difference in these therapeutic intervention responses for any of these measures. So no effect on what appeared to be happening in terms of the care on these wards. And so not surprisingly, we saw no effect on progression of acute kidney injury. It was 16 to 17% in both groups, and no components of composite outcome were influenced by the intervention, and none of the secondary outcomes, including the recovery of kidney function, was no different in either group, or were the number of days in hospital. So this intervention that included education and an electronic medical record-based kind of support tool for AKI recognition management didn't change any of the testing or interventions among hospital patients or result in less progression or better kidney outcomes. This type of use of alerts has been studied in many other places. They're broadly implemented in the United Kingdom, and they have been studied in some randomized controlled trials in the United States. And this is the largest one from Yale, which is a patient-level randomized control trial in their electronic medical record, where they actually, at the patient level, randomized patients with acute kidney injury to receive alerts within their medical record. So this is actually what an alert looked like in those trials. It would actually show the creatinine and identify the patients having acute kidney injury. And this apparently would pop up the first time you logged into the electronic medical record for any patient on your roster who developed the AKI criteria. And these were linked also to an order set. So it could go to an order set that was really focused mainly on testing. So laboratory investigations, imaging, fluid monitoring, but no fluid orders. And this patient-level randomized trial, it screened just over 7,000 patients. Most were included. There were a few technical reasons based on the EMR and the fact that there was a repeated alert in a similar patient, and the fact that there were a few upgrades to the system, but otherwise most patients ended up being included and automatically randomized within the electronic medical record to the alert group and the no alert group. And with this all being embedded in existing records, there were no losses to follow-up. And this is the primary outcome. They had a very similar outcome to what we did, which was progression of acute kidney injury, dialysis, or death, but within 14 days. And they showed, again, no difference between the two groups. And no differences either in their secondary outcomes, which were components of that composite primary outcome, including dialysis, progression based on creatinine, and death at 14 days, discharge to home, or the median length of stay in hospital, and also no difference in the duration of acute kidney injury in this study. And much like us, they also really showed that there was really no, or really I would say negligible, effect of the intervention on diagnostic or therapeutic interventions. Yes, there are some small increases in orders for intravenous fluids, but these were only between 1% to 3% absolute increases in those types of interventions, and many of them there was no difference. And actually, in terms of medications, really medications that could affect kidney function, again, there was no significant difference between the groups in any of these, including aminoglycoside antibiotics, NSAIDs, RAS inhibitors. So the last little part of the talk, I just wanted to end kind of by a little bit of reflection and lessons learned across these various different trials, pragmatic trials in acute kidney injury. And although, we may in the end just not have effective therapies to reverse acute kidney injury in its early stages, as opposed to perhaps we have some ways to prevent acute kidney injury, I do think there's some interesting differences in the way these different interventions have been implemented that may actually underlie some of the differences from the prevention pragmatic trials to the early intervention recognition and response acute kidney injury trials. And I think this really comes back to some of the principles from implementation science and knowledge mobilization that have been shown and believed to actually underlie changes in behavior that might go on to modify clinical outcomes. And this is a representation of the COM-B framework. So it stands for capacity, opportunity, motivation. And these are important elements to influence changes in behavior, in these examples, mainly those of physicians. So capability refers to, really giving the physician the knowledge, the ability, the skills to be able to follow or implement or make a change in a desired way. Opportunity is about providing the context and the supports and the resources to enable you to do it. And then motivation is the desire to actually want to do any of this and to actually carry through on it and make a change and sustain it. And so these are all really important. And I think, education is, or engagement is really important to build and ensure that the physician has the tools and the capability, that they buy in and are engaged in it, and that they understand how to access any resources and tools and use them to their benefit. So reflecting on the studies that I've done now with these prevention in the cardiac catheterization units versus the early response to acute kidney injury on the surgical wards, ended up being some pretty significant differences in how the implementation developed. And I think it was very important and had an effect on what we were able to achieve. In our cath lab prevention study, we were really lucky to have some really engaged invasive cardiologists who served as the site leads and champions, and actually met one-on-one with each of their colleagues to go through an educational program that was CME certified. It gave Section 3 credits, and actually really engaged them in the project. And I think this was really critical to garner their buy-in from the very beginning. And every physician received this before they started to receive the decision support interventions and audit and feedback. This was really hard to do anything similar on the surgical units, because we had so many different surgeons rotating on and off, being on service, different residents coming in, for their monthly rotations on surgery. And the reality of the surgical wards where we worked was that the residents were most of the people actually responding to these alerts. And so it was very hard, despite trying to set up some educational sessions in half days and do grand rounds to surgery, it was really hard to replicate that same level of engagement that we had with those site champions in the smaller clustered cardiac catheterization units. We were able to, I think, integrate the decision support tools in the clinical information system in the cardiac catheterization lab in a much more integrated way within workflow than we were able to do on the wards. And part of this was just the nature of the environment. In the cardiac catheterization unit, it's a very kind of protocolized way. You have a way of bringing in the patient, certain steps the nurses do, certain steps a radiation technologist does, certain steps a physiology technician does, certain steps the post-procedure area does. So we were actually able to integrate steps that use the decision support tools to execute the risk models, to have a timeout, to review the safe contrast limit, to review the fluid orders in the post-procedure recovery area, really taking the tools and actually fitting them into workflow and having dedicated steps where they were incorporated into care. On the surgical wards, this was really impossible. We did try to work to develop a process so that the alerts would be identified and communicated in rounds on every unit. On some units with pharmacists, we actually tasked the pharmacists with this. On others, there was a clipboard, that notes were left on physicians, and so they were printed out and left on those clipboards for the surgeons when they did come and do their rounds. But it was very heterogeneous in how rounds would be done one week to another, or we really could not successfully, I think, develop as integrated a process. In the cardiac catheterization labs, I think we had a very nice, easily understood intervention that could really be focused. We could focus on those elements of contrast volume and fluid therapy. We could pair those elements with not only from the decision support tools, but also with in-person reminders from the allied health staff to remind the physician to look at this. So it provided, I think, the physicians with a much more clear, actionable guidance at point of care. Whereas again, in that environment on the wards where these AKI alerts could occur at any time, and the processes for reviewing them were more fragmented, this was much more challenging. And then we did not have a effective audit and feedback strategy in our study on the surgical units to the comparison that we did on cardiac catheterization units. And I think the audit and feedback was actually quite important for our study as well, because it really did, again, sustain engagement, a sense of accountability to this and focus on it from the groups, and really help maintain and garner buy-in throughout the length of the study. So I'm going to end there just with those reflections, and just say thank you to our research group at the University of Calgary and the University of Alberta as well, who helped us with these studies across Alberta, as well as we had some patient partners as well who helped with us on each of these trials, and really the clinical staff, the surgical groups and the cardiology groups who tolerated a nephrologist talking about kidney injury and doing that in their areas. They were really good to work with. So yeah, thanks a lot. I'll stop and happy to take questions or further discussion about this type of
That's
work.
great. Thank you, Matt. I think I speak for myself, but I'm sure many of my colleagues are a bit jealous of how you've been able to embed decision support tools within your EMR. Many of us have, in this province, you may know, we have multiple EMRs, but to my knowledge, I don't think we've been successful in embedding such things. I think you raised some really interesting points about the repeated nature of the cardiac cath lab and the things that you can do in something that is very systematic, as opposed to random surgical events and the interventions you can make. But I think it's very sobering, and really congratulations to you and the team for putting in the work to understand what does and doesn't work. And I think for our patients undergoing cardiac cath, if we could systematically implement something that could reduce acute kidney injury by whatever percentage, I think that would be a bonus. There are some questions in the chat which are more clinical. So recommendations about SGLT2, ACE, metformin, Lipitor, pre and post contrast. That's, I think, an ever-changing thing.
No, it's a good question. We did have that discussion. Should we focus on trying to make, recommend withholding those medications? They already had a pretty clear policy around metformin, of course. That's the one that everyone has a policy on in radiology, it seems. In the end, when we reviewed that evidence, we didn't feel it was strong enough and to recommend, and we figured we would be better on focusing on fewer things that had more evidence. So we went with contrast volume and fluids. Interestingly, that's what they did in Veterans Affairs as well. They focused on those two elements as well. So no, we didn't do that. And when we were doing this, we didn't have the knowledge about SGLT2 inhibitors. And so we didn't even think of that one, but we were thinking more around diuretics and RAS inhibitors, but did not include that. I also see your question there about how we come up with the volume of contrast recommendation. And I glossed over that. Yes. So there's a number of ways of doing that. And there are those EGFR, ratio formulas to try to do that as a simple way, back of the envelope. We used a strategy it's actually a modeling strategy. So you develop a predictive model for prediction of acute kidney injury, and you include contrast volume in the model, and you use retrospective data. And then you decide what your goal is to reduce acute kidney injury, and then you back calculate the reduction in contrast volume you'd need to achieve to do that. And then essentially you run that model for every patient, and that's how you get your safe contrast limit. So that's how we did it. It's actually a technique developed by John Spurtis, who helped us with this. He's a cardiologist in the United States with an interest in this area. So we used that modeling approach.
And I guess the real question is, and after the study's finished, are you still using it? Like, so is this what, like when you guys do rounds, this, or the cardiologists are planning caths, you're using these?
I'm told they are. Yes, we are. We did have a large implementation of a new electronic medical record in Alberta. So we had a dedicated one called Approach, which is very similar to Heart IS in BC, that was in the cath labs that we used for this project. But then across Alberta, we're implementing an Epic-based EMR. So we did have to transfer all of our tools over into Connect Care. So that's what we call our Epic-based EMR in Alberta. So that was a large process, but it is still there. We do still have all those functions at point of care in the new electronic medical record, and it's being used. We are trying to get data out of the system, which we have not been able to do yet with the new system, but it's coming, I think, so that we can resume the auditing feedback reporting.
That's what I was going to ask you is, I think we've all learned over the years that like most people get up in the morning to do a good job. If you actually give them an audit review, they actually can course correct because people don't know when things creep in or things start to change. So are the auditing processes still available, or is it planned to be
It's planned, yeah. We're working on basically being able to re-extract the variables out of the new electronic medical record. And actually, in the end, I think we will get to a better place with it. It's always that challenge, you change systems and everything you had is lost and you have to recreate it, which feels defeating. But one nice thing about the Epic platform is it actually has more dashboards for actually reporting, your own practice data in the system. So what we had to do before is take an extract from the clinical information system. We had an analyst team running those numbers and producing the reports, and we were mailing them out or having them distributed in rounds. I think the new model we're working towards is it will actually be in the system. So you'll be able to go into, they call it My Dashboard, and look at your metrics.
That requires, to your point before, in terms of motivation, you'll have to want to click. Sometimes it's nice when, even if you don't want to know, someone sends you your report, but
yeah,
that's
it'll
good.
make
It's
it
good if it's automated, but you still need to look at it.
I agree. Like we've been thinking about that a lot. It will make the access easier, but if it just becomes like, I think a successful part of our auditing feedback was also, it was incorporated into the invasive cardiologist round. So they actually reviewed, they had a group session where they would everyone would get their own report, and the site lead would go through the performance of the site, and each person would be seeing their own. And so there was that moment of reflection and discussion and, some chat about, well, how do you, there's these technical things that I don't know the details of, but yeah, we'll have to be careful not to lose that, because I think that's
that I suppose you could audit how many times people are accessing that and or using it in rounds. I'm conscious that I seem to be usurping the question period, so I just want to make sure that if anyone else has a question, you can raise your hands. You have over 50 people on the call today from all over the province, which is fantastic, and obviously a topic of interest. So I'm curious if anyone else has questions or comments. Oh, hold on, here I see something. Oh, no open questions. Yeah, no, I think, you've given us pause. I think, a couple of things. Acute kidney injury remains an important component and a contributor to chronic kidney disease and change in trajectory, and hence all of the interest in it. And whilst at the moment we may not have lots of interventions, over time we hope to, but I think you've also demonstrated how one can execute like a complex intervention, and that's what these sorts of behavioral changes take. It's not a magic bullet, it's not a pill that will change everything. It's education and feedback, and how do you use electronic medical record better? And this is ideally what it should be good for, right? To take away human error.
Yeah, I think it brings the opportunity, but one thing I realized from it is it kind of needs to be, and I think this could be true of all decision support decisions. It needs the secret sauce around it, with these other elements to engage and make it effective. Within the decision support literature, there are the guidance around, the importance of integrating into workflow. So it's not, alerts can be annoying and there's a lot of frustration with.
I was gonna say, it's like there's always, like, if we can't lose the humanness, right? I think someone caring about it and someone watching and being a champion is still part of it. Jocelyn was asking a question in terms of CT, if you could apply some of these to CT scans, and I guess that brings up the controversy of intravenous contrast versus intraarterial contrast, which.
Yeah, hi Jocelyn. Yeah, good question. It is a lower risk, generally with intravenous contrast. And so there's been that the radiology literature, which, with propensity score matching and observational designs that have said there's no difference in risk of acute kidney injury. But this is also playing out in an environment where higher risk patients often will get fluids or sometimes reduced contrast as well. But we haven't done it in this group because I think the risk is lower. The amounts of contrast in some of these coronary procedures it's intra-arterial, it's much higher volumes. The incidence of acute kidney injury is higher. So I'm not thinking of trying to do all of the CT scans, although, there could be places like, in the vascular interventional suites where there's still intra-arterial contrast, being done where this could be applied. So I think it can extend outside the cardiac catheterization units, but I think probably I would still be a little more selective across all contrast exposures, because I think in our trial, we only focused on people with a more than 5% or higher risk of acute kidney injury to kind of, again, focus on the higher risk group, because as we know, there'll be a lot of patients who have procedures and do fine with their kidneys.
Yeah, I think that's a really important point. And there's, still, I think, amongst even the radiology groups, perhaps still a little bit of confusion around intravenous versus intraarterial contrast and the true risk, because people I hear are still being denied CT scans because of their kidney function, even though the risk is really low. But that's a different kind of education. But
I just was recalling the question earlier about what to do in the heart failure patients. Yeah. We did not recommend the LV-EDP guided fluid therapy for patients with with heart failure with reduced LV function, mainly because that Poseidon trial excluded that population. So the heart failure subset of our group got much less fluid and a larger emphasis on reducing contrast volume in the end. So I think that's still a more challenging group.
Yeah. Oh, another question. Many patients have hyperuricemia, and contrast may cause acute uric acid nephropathy. Would you suggest including checking uric acid as part of the
yeah, thanks, Ron. Yeah, I hadn't thought of that. Yeah, we have not looked at that. I suppose hydration could be helpful here in that scenario, but we didn't build that into this initiative, or we haven't looked at that. So thanks for that suggestion.
Yeah, and I think the NAC discussion is over. There is no evidence to suggest that NAC is in any way beneficial.
I think so now. Yeah, we have some good large randomized controlled trials with very, methodologically robust, and, some of the meta-analyses really show that, some of those smaller early trials that showed benefit had some limitations in their design. Whereas if you look at the higher, if you stratify into the trials that had allocation concealment, blinding, and low losses to follow-up, there's really no effect of N-acetylcysteine, and sort of that other literature and the heterogeneity across all the trials is really being driven by smaller trials that lacked some of those elements. So I think the argument is over.
Yes, thank goodness. Giving medicines that don't do anything is good. Well, listen, I really appreciate you taking the time, more importantly, for all your diligence in this area and for also demonstrating, and I think for us in BC, like the value of this stepped wedge design, which is very implementable across a province, you know, the way that you've described it and something that we aspire to. And the complexity of interventions and how they need to be organized this way. So thank you very much for that demonstration and your contributions to the area. Oh, and I think there might be one more question. Oh, just a great presentation. Yes. And I want to, yeah, I think it was an excellent, very clear presentation and very relevant to our clinical practice day to day. So again, thank you for making the time and appreciate everything.
Thanks for
everybody.
having me.
Bye.